Hello there, and a very warm welcome to this first Podmedics podcast of 2010. During this podcast, I'm going to be talking about migraines. Particularly, I want to focus on some simple definitions, common epidemiology, look at the etiology of migraines, the important clinical features, and then finally focus on the management. So, let's start with the definitions. What exactly is a migraine? A migraine is a recurrent or paroxysmal severe headache that is often associated with systemic upset. The two most commonly affected organ systems are the visual system and the GI system, but we'll talk a little bit more about this later. Migraine is probably underdiagnosed in the UK, and often medical practitioners have quite a difficulty in distinguishing a severe tension type headache and a migraine. Migraine is also common, probably more common than you might think, affecting up to 10% of the population. It's much more common in women than men. Migraines usually start in childhood or young adulthood and tend to decrease in severity with age. The precise details of the etiology of migraines is probably beyond the scope of this podcast, as it's something that's still being widely looked into. However, migraine may be associated with certain environmental triggers, which we'll talk about in a bit. The mechanism of pain and aura is thought to be due to meningeal and vessel pain receptor activation, as well as central pain modulation, particularly in an area of the brain called the dorsolateral pons. Much more importantly, there are lots of different subtypes of migraine. The two most common subtypes that you'll come across are classical migraine and common migraine. Classical migraine, or migraine with aura, accounts for about 20% of migraines, while common migraine, that's migraine without aura, is about 75%. There are also some other important types to be aware of, including hemiplegic migraine, ophthalmoplegic migraine, and basilar migraine. However, these are all quite rare, cumulatively accounting for around 5%. There are a number of triggers for migraines, which can be broadly divided into 5 different categories. These are emotional triggers, physical triggers, dietary triggers, environmental triggers, and medicinal triggers. Important emotional triggers include stress and anxiety, and physical triggers are tiredness and long-distance travel. There are lots of different foods that have been associated with migraine. These include alcohol, tyramine-containing foods such as cheese and chocolate, as well as caffeine. In addition, just like in epilepsy, certain environmental triggers can cause headaches. These include bright lights, flickering lights, certain noises, and sometimes even certain smells. And finally, certain drugs are associated with migraines, particularly the combined oral contraceptive. The clinical features now. Let's start by talking about the general features of the headache that we see in migraine. As already mentioned, in a migraine, the headache tends to be severe. However, importantly, it is not always unilateral. Also note that it is not always associated with aura. Remember that classical migraine only accounts for 25% of all migraines. The headache may vary in its duration from between 4 to 72 hours. As already mentioned, there are important additional features, and these are nausea and vomiting, that's probably most common in migraine, and in addition, photophobia, that's sensitivity to light, and phonophobia, that's increased sensitivity to noise. In classical migraine, we see other features apart from the headache. These include a premonition that occurs hours to days before the onset of the migraine, and this can include really quite bizarre things such as an increased amount of tiredness, cravings, and sometimes even excess yawning. The aura is what's typically associated with classical migraine and usually starts up to about 1 hour before the onset of the headache. You can broadly divide aura into 3 sets: visual aura, sensory aura, and motor aura. In visual aura, there can be zigzag lines, field defects can be seen, and tachypsia may also occur. This is described as flashing lights in the visual fields. Sensory features include spreading paresthesia in the legs, arms and face most commonly. Lastly, and perhaps most rarely, one can also see motor features such as aphasia and hemiparesis. And then finally, in classical migraine, there's often a resolution phase where patients describe feeling excessively tired. It's very, very important when you're considering a diagnosis of migraine to think about a couple of additional differential diagnoses. These include, most importantly, meningitis and subarachnoid hemorrhage, but other differential diagnoses might include temporal arteritis, TIAs, and uncommon forms of epilepsy. In order to help you distinguish important differential diagnoses, it's important to have some red flags in your mind. If the pain is of sudden onset, then one might think, for example, of a subarachnoid hemorrhage, where the patient will often describe the worst headache of their life. If there is fever, one might think about meningitis. Meningism, of course, could be associated with both meningitis and subarachnoid hemorrhage. The presence of neurological signs and symptoms are quite rare in migraine, and it's important to consider other diagnoses if you see these. And finally, temporal artery tenderness is particularly associated with temporal arteritis, which of course is an emergency which requires steroids and further investigation. So finally, let's move on to talk about the management of migraines. There are two aspects to consider in the management. That is the management of the acute attack and prevention of further attacks. During the acute attack, patients are often recommended to lie down in a darkened room. There are a number of important drugs that are used. First of all, we'll talk about analgesics. These include paracetamol, aspirin, and ibuprofen. Analgesia is best taken early in a migrainous attack when absorption is least inhibited by gastric stasis that tends to set in during the course of a prolonged migraine. Next, we think about antiemetics, particularly metoclopramide and domperidone. Metoclopramide and domperidone, as you may know, are gastric stimulants and increase gastric motility, and therefore they are often best taken together with analgesia as they will increase the effectiveness of the oral analgesia. Additionally, they'll also help with the nausea. If vomiting is really severe, then it is possible to use diclofenac and domperidone suppositories. Next, we come to triptans. Triptans, such as sumatriptan, with which we have the most experience, stimulate 5-HT1 receptors in the brain and are indicated for use when analgesia is ineffective. With triptans, the advice we give to patients is a little different. We advise them not to take them too early in a migrainous attack. For example, they should take them not when they get aura, but when they get the actual onset of the headache. One of the recognised problems with triptans is relapse, and the figure for this has been estimated at up to 50% in 48 hours. Prevention is increasingly being recognised as a very important element of migraine treatment. At its most simple, we can recommend trigger factor avoidance, and this may reduce frequency by up to 50%. It's important to consider pharmacological prevention if patients are getting greater than or equal to 4 attacks per month. Regular prevention reduces both the frequency of attacks and their severity. Important drug therapies to be aware of are beta blockers, which are used first line, such as propranolol, anti-epileptics, such as sodium valproate and topiramate, and finally, antidepressants, such as amitriptyline. A recent review article in the British Journal of General Practice showed that doctors in the UK underuse preventative therapies, but patients will accept these therapies quite well, and there is a good response usually to such treatment. So that's it for this quick podcast on migraines. To summarise, migraines are common, affecting up to about 10% of the population. They are defined essentially as recurrent, disabling headaches where there are often additional features such as nausea, vomiting, photophobia, and sometimes phonophobia. It's important with migraines to remember other causes of severe headache, particularly meningitis and subarachnoid hemorrhage. Remember all of those different precipitants that can stimulate migraine and try and ask about them in your patients, because advising them to get away from these things can reduce frequency by up to 50%. Remember that in classical migraines there are often additional phases. And finally, remember that the management can be divided both into the management of the acute attack and prevention. And in the acute attack we use analgesia plus or minus triptans, and for prevention we tend to use beta blockers and sometimes anti-epileptics. So thanks for listening to this first podcast of 2010, and I hope to see you all again soon.